Hello Malaysia and welcome to another edition of Medical Today. I'm Gerard Ratnam, and on today's Medical Today we'll be taking a look at gastroenterology or gastro problems. We'll also be taking a look at sports injuries. In a short while we'll be zoning into the meniscus problems that we all face, especially sportsmen. But for now, what we want to talk about is muscle and joint pains. It slows us down when it comes to having a lifestyle, or probably an active lifestyle. You have joint pains and it gives you a lot of psychological problems when you have to deal with them and also carry on exercising. Now, to talk about the topic and of course to give us more information on what muscle and joint pains are all about, we have in an interview with us Encik Zulhazri Razali, the Director/Pharmacist for the Commercial Division of Pharmaniaga Berhad. He talks to us about what muscle and joint pains are all about. Let's take a look at this interview.
Okay, normally muscle pain appears when you overstrain or you over-exercise, or sometimes you have recurrent pain because of inflammation of the joints, things like that. It's all about the inflammation of the tissue of the muscle, and you can feel it when it becomes severe, and that is when you need some treatment. Okay, normally we restrict the movement, right? But more often people are looking for immediate solution, which is applying some creams or ointment, right, to feel the relief in that particular area. Okay, when you talk about muscle rub or joint rub, there are so many ointment and creams in the market that we can use to relieve the pain. Of course, when you look at the physiology of the pain process in the muscle, they got a few processes where you can identify why the pain arises and how you can treat them. Okay, most of the products in the market mainly are the menthol thing, and you feel the heat, or sometimes you feel the cooling part. Subsequently, you feel the heat. It's all about how to relieve the pain sensation. Okay, Pyroxene is slightly different from the normal muscle rub. It's from the herbal extract. Okay, the active ingredient is from the natural product, and it is categorized as non-drug. It's a medical device, in fact, and they act basically on the area where the process of pain chemicals in the muscle arise. Okay. So basically, it relieves the pain by stopping the chemicals released in the muscle, so that your brain won't translate into pain more than what it should be. Okay, Pyroxene is from Europe. It is produced from herbal extract. Okay, it's slightly different from the normal muscle cream. The mode of action is different. Okay, it's more acting on the chemical release in the muscle, and it's not the heaty cream, and it's not greasy. Okay, it's well convenienced to be used by all ages, including children or pregnant women. It's very safe. It's a medical device category. Definitely it's not a drug, so you can find in many pharmacies in the street, especially at our Royal Pharma. And this cream can be applied at the area where you feel the pain, and the relief will be felt quite instantaneously. Okay, you can apply as regular as possible, and most important, you feel the comfort when applying Pyroxene. Pyroxene acts on the first level of pain process in the muscle, where the arachnoid acid is released from the membrane. But the specific mechanism was not identified because this is basically a non-drug. So those herbal extracts in Pyroxene, they claim that acts on those areas where the arachnoid acid was released. It's different from the other painkillers where they treated specifically on the level of below arachnoid acid. So what I can suggest is to use this Pyroxene when you feel the pain on your muscle, on your waist, on your shoulders, so that it can give you the relief and you can feel the difference before and after. Again, it is not a drug, and it's never be in the drug category everywhere in the world. The main significant or the clear difference between Pyroxene and other products is it is not heaty, it is not greasy, and the texture is so smooth that you can feel like applying a moisturizer. Okay, so it is good for working people or those people going to the office and need something to relieve their wrist or fingers or knee, and it is suitable at any time of your day life. People of all ages, from young to old, at certain point of time will have a muscle pain or joint pain or frozen shoulders. Pyroxene is a product of choice because you can apply without any worries about side effects or any discomfort, because the formulation or the cream itself, it feels very smooth, and I believe you can feel the difference once you apply one or twice a day with Pyroxene. Okay, you can get Pyroxene in various pharmacies in Malaysia, mainly in our Royal Pharma and some selected individual pharmacy. You can seek some advice from the pharmacy. They will explain to you about Pyroxene and also the things that Pyroxene differ from the normal muscle rub. And I believe once you try Pyroxene, you can feel the difference.
The Nation, a talk show from the Current Affairs desk with in-depth conversations on health, women, property, culture and performing arts. Only on the Nama News Channel.
Listen to views of industry captains. Analyze and examine trends and projections. Gain market insights from subject matter experts. Biz Talk every Friday only on BNC.
Do you know what really happens to your mobile e-waste? Throwing them into the dustbin will only result in choking the landfills. Did you know that over 42 million mobile e-waste are not properly disposed of? And this amount will continue to grow. This will potentially cause toxic chemicals to seep into the ground. The environment will slowly be polluted, thus creating a multitude of health problems to us humans. Did you know that 90% of the materials used to make mobile phones and their accessories can be recovered and recycled? These can be reused to make anything and everything, including electrical goods. Well, the good news is MCMC has initiated a mobile e-waste campaign. MCMC, along with telecommunications companies, have set up collection areas for the public to safely dispose their mobile e-waste at participating outlets. With 72 outlets nationwide including TM, U-Mobile, Maxis, DG, Celcom and Altel, you can now dispose your e-waste easily and at your convenience. Join us to get 1 million recycled mobile e-waste for this campaign. Make a difference for a better world, better environment and better future. For more information, log on to mobileewaste.mcmc.gov.my. This initiative is brought to you by the Malaysian communications industry together with MCMC.
Hello Malaysia and welcome back to Medical Today. I'm Gerard Ratnam. From what we spoke about just before we went for the break, let's take a look at sports injuries, something we did last week or a couple of weeks ago. And to join us in the studio once again, or rather for the first time, Dr. Shamsul Iskandar bin Hussein. He is a consultant orthopedic surgeon from Ramsay, Sime, Darby Healthcare. He's here to weigh in on what sports injuries are all about. Well, thank you very much for joining us, Doc. You've brought along a whole set of goodies with you to talk about sports injuries. Right. And rightly so, just before we got into the studio, we talked about how technical we can get sometimes when we talk about medical procedures or medical problems. Exactly. Now, you want to make this simple for us. I think that's what you want to do here today. Right. And you want to talk about sports injuries. So. Correct. And I think, if I'm not mistaken, you've picked the meniscus to be talked about. Why is meniscus your choice of something to talk about today?
Right. Okay. Firstly, I would like to thank you for inviting me to share my experiences with regards to this injury, which is the meniscus injury. Namely, the reason for me choosing this topic because it is one of the most common injuries which I see in my clinic setup. Okay, as you know, that one of the common outdoor activities that we to lead a healthy life, performing exercises such as running, jogging, or playing field soccer or football, or for that matter, also doing aerobics or indoor gym training. Right. So one of the injuries, or one of the common injuries sustained, besides having sprains and strains to the muscles, to ligaments, is actually the lower limb injuries, which namely within the knee joint itself, there's a structure called as meniscus. Okay, and this meniscus actually has a lot of functions to our body. Right. Namely, one being the cushion or the support for our knee joints, provide stability, restricts our movements as a protection to our knee joint.
Maybe you can show us where the meniscus is and also walk us through it.
Yes. So we do have a pair of meniscus. This is actually a fibrocartilaginous tissue, which is actually present above the surface of the tibial shin.
Right, so it's a fibrocartilaginous tissue.
Correct, yes. So, namely, it has two sets of fibers. One which actually radiates surrounding it, they call it the radial fibers, and the other, the fibers which is actually parallel to the surface of the bone, which is called actually is the longitudinal fibers. And these two fibers, which forms the meniscus, performs the function as what have been said earlier. Most importantly, as the cushioning effect and also protecting the cartilage.
So sort of a buffer cushion.
Yes, exactly. Right.
So what happens when it starts to wear out?
Yes. So there are namely two types of injuries experienced by people. One is a traumatic tear, all right, due to a sudden acute blunt force to the meniscus, which causes the tear to which causes the meniscus to tear or to rupture at the extreme state, or due to the wear and tear itself, which is called as a degenerative tear.
Right.
These two can happen during our during life. All right. So as you were asking about with regards to the tear, the types of tear, traumatic tear normally occurs during sporting activities. When you are doing when you are running, you are jumping, or you are landing in an awkward position. Okay. Whereas this degenerative tear, it's due namely old age, and of course the most prevalent factor is the weight factor. Being heavy itself predisposed to this degenerative tear.
Right. So let's talk about the latter now, degenerative tears.
Yes.
You say it's about age, probably about weight.
Yes, exactly.
It's also something that comes with signs and symptoms. You get early signs and symptoms.
Yes.
A lot of us overlook these symptoms. Just a little pain here, like it's going to go off. Now, when do we know that we go and we need to see our primary care or our primary healthcare provider to find out what's going wrong there? So sometimes you get a bit of a dull ache and it'll go off, then it's done. So how long must this ache or pain or signs and symptoms have to be there before I report this to my doctor or my family doctor?
Well, the problem is that within our knee itself, there's many structures present. Okay, it can be the ligaments, it can be the cartilage, it can be the meniscus, and also it can be the muscles. So most important is to identify what is the proper diagnosis, so that then only the proper treatment can be initiated. As to what you have mentioned, how or when is the duration, or when do you need to see a doctor? Well, as soon as possible.
Right. So if it's knee pain, there are variables in play here, and we need to find out what these variables are.
Exactly.
Right.
Yes. Yeah. So in these instances where you find that when the symptoms, like when you're sudden deceleration, when you stop when you try to stop after running, you try to prevent a fall or something like that, then you hear a popping sound.
Right.
Okay. Or suddenly you notice that there's a gradual swelling to your knee, and of course the other symptoms of pain, all right, or there's a bruise present, or locking of the knees. They call it the lock.
So if your knee is out, when you lock it outward,
locking of the knee means that you're unable to extend the knee from basically from the flex position.
Right. So from here to this.
Correct. Yeah. Yes. So when this happens, this is actually considered as an emergency. Okay. Well, emergency in the sense that you cannot perform your normal day-to-day routine or activities. So this necessitates you to see a doctor. If you have the facilities or the means to go to the hospital, by all means then.
Right. Before we get into looking at your toys and the different things we can find out from what we have here, let's talk about the people who are coming to see you. Now, there's a lot of talk about jogging. Some say it's good, some say it's not so good. people, there's a Japanese lecturer or a Japanese scientist who's
Yeah.
come up with mid-foot strike. It's called slow jogging.
Yes.
You know, because they say people are hurting their joints. So what's the truth about exercise? People are playing futsal,
Right.
football on hard courts these days.
Correct.
That can't be good for your knees.
Definitely. Yeah. With regards to exercise alone, it is advocated. Yeah, because in our modern living, our nature is that we are always sedentary. We are always on our seats, just like we are now. Yeah, most times in the city, the lifestyle is that you sit in the car driving to work, and then when you reach the office, you sit on in front of your desk, in front of your laptop, and you do your typing, or you do your writing letters or documents. You'll be sitting for more than half of your day.
Right.
All right. So, and our body is not actually meant just for sitting. Okay. So, in order for us to be active physically and also mentally, exercise is not only must; it should be mandatory.
Right.
All right.
Exercise
Yes.
is a must for everyone.
Correct. It is. How else? Okay. I think we can cancel that because I want to comment about our Prime Minister.
Okay.
Okay. Nonetheless, the issue arises that exercise is actually good for the body because, in a way, it prevents all the lifestyle diseases. You can avoid developing diabetes, hypertension, and raised cholesterol level. Those actually have been shown to be reduced by doing exercise alone.
Right.
And for this matter, running or jogging is good because it provides so-called the few of the exercises. One of them, besides the physical exercise, is actually the aerobic exercise.
Right.
Okay, where it helps to exercise your lung functions, your breathing, and also, of course, the blood circulation.
Right. But what's interesting here is that
Right.
some of us,
Yeah.
you know, we have joint pains, and that
Yes.
inhibits us from wanting to go out. It doesn't motivate us.
Correct.
And we are afraid that if I do go out there
Yes.
and be active,
Correct.
my joints are going to hurt even more.
Exactly.
Well, we're going to take a short break.
Yeah.
When we come back, you're going to walk us through meniscus pain, what it is,
Yeah.
and what we can do,
Correct.
or what we shouldn't do.
Sure.
All that and more. When we come back, right here on Medical Day,
Yeah.
we're joined by Dr. Shamsul Iskandar from Ramsay, Sime, Darby Healthcare. Stay with us.
Kalau kau nak kau bayarlah. Aku mana ada duit. Ni aku sedut, nanti aku datang bawa duit. Aku bagi kau Boleh lah. Hey.
Ali! Ali! Itu bangka mamak dengan duit mak kamu nak buat apa dah beri dada?
Jauhi dada. Dada membunuh.
Medical awareness at your fingertips. Surgical procedures and understanding the human body. Critical conditions need critical answers. Catch us on Medical Today to find out more on Ramsay Sime Darby Healthcare, only at Banama News Channel.
Brings you the latest in current affairs, lifestyle and entertainment, as well as one-on-one discussions with fascinating personalities. Only on Banama News Channel.
Gain insights from the people with the capacity to translate vision into reality. Interviews with corporate leaders. Monday, only on BNC. Hello and welcome back to Medical Today. I'm Gerard Ratnam, and together with me we do have Dr. Shamsul Iskandar bin Hussein. He's a consultant orthopedic surgeon from Ramsay Sime Darby Healthcare, talking about sports injuries, more importantly focusing on the meniscus. Now, a question for you. If you have knee problems, who treats you?
Well, I have my colleagues, the other doctors.
The other doctors,
of course.
Now, do you actually self-diagnose sometimes?
Definitely. Because based on my experience and my expertise, I will try to deduce what is it exactly. But nonetheless, I will get the confirmation by my colleagues.
Right. That question came from one of the production crew. You know,
I see.
All of us have joint pains, and we always have to get a second opinion. Now, going back to the meniscus, you wanted to show us how what signs and symptoms come about, and what we can do. So let's just start with how you investigate meniscus problems or injuries.
Well, Gerard, the first thing that most important actually is the history. Well, by acquiring the appropriate or the exact nature of the mechanism of injury, the duration, the location, and also the intensity, I can deduce what sort of tissue injuries does the person suffers from.
Right.
Okay.
So you're sort of a Sherlock Holmes also.
Yes, definitely, because we have to do all these so-called deductive deductions to rule out any other possible causes, but at the same time to narrow down the possibilities to the injury.
Right.
All right. Once we determine that the possibility of a meniscus injury is present, we also have to confirm it, all right? And by how to confirm it is normally we do some of the special tests. There's some special tests or maneuvers that we perform on the person, on the patient himself, on the bedside, by the bedside itself. These special tests called McMurray's test, Tersali test, pivot, all these tests.
So the various tests for you to ascertain what the problem is, or just get close to where the problem is.
These are actually the clinical examinations, all right? Because some other injuries may also mimic meniscus injury. For example, the cartilage. Because although when you perform all the special tests, we still cannot narrow down all this the injury, all right? So the next step after the clinical examination are the investigations. Okay, and for the meniscus injury, normally there are two sets of investigations done. One is the non-invasive, and the other is the invasive. Okay, so the non-invasive, the benchmark for meniscus injury is actually magnetic resonance imaging, MRI, because as you know, MRI can show everything, almost everything, but it depends on the specialists of the imaging or the radiologists to determine or to basically identify those injured structures.
So very quickly, how much does an X-ray show you that, that you need to take an MRI? Because some people believe that, oh, the doctor is wanting to do an MRI because he wants to charge us more, but that's not the case.
Definitely.
So what does an X-ray do? MRI does that an X-ray does not do.
Okay, good question. X-ray actually is a radiation equipment which sends this radiation and determines the calcium content of the structure. As you know, bones has a lot of calcium composition. That's why it can be visualized by X-ray, or the other name for it is Roentgen. All right. Whereas MRI actually detects the numbers of the hydrogen ion isotopes, and this is translated into images, and these images actually will be analyzed by the radiologists and will be interpreted by them, and in turn MRI is basically can detect most of the structures, or if not all. It will show and illustrate the structures in the limbs or in the body for that matter. Whereas for the X-rays, it's only done to determine the condition of the bones plus the joint structures. Right. So meaning the bones and the joints. So
the MRI is sort of a gold standard in ascertaining what the problem is?
Not true actually. The gold standard for investigation for the knee joints, in this where the meniscus is located, is actually the fiber optic procedure, which is called arthroscopy. Okay, because arthroscope is where by performing a keyhole incision to the knee joint, and you poke inside the joint a camera which magnifies the images.
Right.
So this is actually the gold standard, but it's an invasive procedure, and it's usually routinely done when you're performing surgical treatments after the diagnosis. So that's why there are actually the benchmark. One is the non-invasive MRI, and the other is the invasive, minimally invasive arthroscopy.
Right. Now coming back to the meniscus injury, you wanted to show us something on this model here.
Correct.
Okay.
So when there is actually injury, twisting injury to the meniscus, so the meniscus may get torn within the area, and it may actually slip out. And when there is a slippage, or there is actually slippage to the meniscus, it can actually lock the knee, and this prevents the knee from extending. All right, and besides that, there will always be a development of bleeding inside the joint, which is termed as hematrosis, and this will cause the swelling to the knee. All right, and but namely, besides the injury to the meniscus, sometimes the neighboring structures, such as the cartilage, may also be scuffed out by this meniscus, leading to cartilage injury.
Right.
Okay, one of the problems leading to osteoarthritis later on. All right.
So it's like bad news. So do you have a view of what it look like if there's cartilage problems?
Yes, I do. Yeah, exactly. So here I would like to share with you a structure of a cartilage, which is actually, this is just a depiction of how it looks of a healthy knee joint with the cartilage intact. Okay. And the other one, once there is an advanced osteoarthritis arises, there's a wearing off of the cartilage, exposing the bare bone side.
So when cartilage wears off, this is what it looks like.
This is one of the end stage of this osteoarthritis. Right.
Well, very quickly, we've got about 3 minutes left. If we can quickly talk about preventive measures and how important accurate diagnosis is.
Correct. Yeah, most of my patients, or most of the athletes which were seen by me, always have a question, which is, how do I prevent those injuries, or how do I prevent getting injured, all right, from meniscus injury? So my advice is actually, one is that the first thing is you have to have a good so-called, you have a strong and also healthy leg, meaning that you have always been on regular exercise, okay, to make it strong and to make it stable. And secondly, you must always be so-called you shouldn't be fatigued, or you shouldn't be tired when you are involved in games, because when you are tired, there's a liability
that you get injured.
You get injured.
Right.
All right. And thirdly, when you are involved in sports, so-called the courtyard sports or the indoor games, it's a matter of your footwear.
Right.
Okay. Wearing the appropriate footwear, all those suitable shoes, and not wearing old steel shoes, those are actually preventing you from getting all these injuries.
So depending on what sport you're doing, you need to figure out what is good footwear for that sport in which you're taking part in. Right.
Yeah.
Right.
And of course, the other thing is that before starting any games, you have to perform all those stretching, strengthening, warming up exercises, because this will keep your muscles, your tissues alert, and thus preventing from having any accidental injuries.
Right. It's very interesting. You're ending with that, and warming up is so important.
Correct.
There's just so many videos out there with ortho surgeons teaching you how to do a decent warm-up. You just go to YouTube and you get a warm-up. So the warm-up is very important.
Yes, it's crucial because in order to avoid experiencing these injuries, it's actually the best way of not getting injured at all.
Right. On that note, Dr. Shamsul, it was a pleasure and an honor having you here. Thank you very much for joining us.
Thank you very much for having me here.
I do hope you gained quite a bit of an insight as to what meniscus injury is all about. We'd like to thank Dr. Shamsul once again for coming in to share with us his ideas and his thoughts on sports injuries right here on Medical Today. Stay with us, we'll take a short break and come back right after this. This is Medical Today on BNC.
Tahukah anda apa yang sebenarnya berlaku kepada isi setelefon bimbit anda? Membuangnya ke dalam bakul sampah akan hanya mengakibatkan tapak pelupusan menjadi sesak. Tahukah anda lebih 42 juta isi setelefon bimbit tidak dilupuskan dengan cara yang betul dan jumlah ini akan terus meningkat. Ini berpotensi menyebabkan bahan toksik kimia teresap ke dalam tanah. Secara perlahan-lahan, alam sekitar akan tercemar sekaligus menimbulkan pelbagai masalah kesihatan kepada manusia. Tahukah anda bahawa 90% daripada bahan-bahan yang digunakan untuk membuat telefon bimbit boleh dikita semula? Ianya boleh diguna semula untuk menghasilkan apa sahaja termasuk barangan elektrik. Berita baiknya ialah MCMC telah mengambil inisiatif memperkenalkan kempen e-sisa telefon bimbit atau mobile e-waste. MCMC bersama syarikat-syarikat telekomunikasi menubuhkan pusat pengumpulan di cawangan yang mengambil bahagian untuk orang ramai melupuskan e-sisa telefon bimbit mereka. Dengan 72 cawangan di seluruh negara termasuk TM, U-Mobile, Maxis, Digi, Celcom dan Altel, anda boleh melupuskan e-sisa telefon bimbit dengan mudah dan pada bila-bila masa. Sertai kami untuk mencapai kempen 1 juta kita semula e-sisa telefon bimbit. Lakukanlah perubahan untuk kebaikan dunia, alam sekitar dan masa depan. Untuk maklumat lanjut, layari mobileewaste.mcmc.gov.my. Inisiatif ini dibawakan kepada anda oleh Industri Komunikasi Malaysia bersama MCMC.
"911" menampilkan pelbagai segmen menarik khas buat anda. Saksikan 911 setiap Isnin hingga Jumaat 9 pagi. Hanya di Bernama News Channel.
Listen to views of industry captains. Analyze and examine trends and projections. Gain market insights from subject matter experts. Biz Talk every Friday only on BNC.
Medical awareness at your fingertips. Surgical procedures and understanding the human body. Critical conditions need critical answers. Catch us on Medical Today to find out more on Ramsay Sime Darby Healthcare, only at Pharmaniaga News Channel.
Bunuh diri kerana dadah syabung. Ha, ini anak Mia lah ni. Ha, sampai masuk khabar lagi. Memalukan kapal kita. Iya, anak Mia lah ni.
Hei.
Betul lah.
Yang ambil dadah aku lah, bukan mak aku lah.
Kau tengok sini.
Hei, pekat.
Weh, Siti. Ayah kau mati sebab dadah kan?
Minggu depan, kalau kau nak bayar, lagi teruk daripada yang aku buat.
Siti takut. Siti jangan takut, Mama adik sayang.
Jangan biarkan keluarga anda menderita kerana dadah.
Laporan pelbagai dimensi memaparkan isu semasa, pelancongan, warisan dan budaya dari dalam dan luar negara. Saksikan jurnal bernama setiap Isnin di Bernama News Channel. Semuanya tentang anda.
Listen to views of industry captains. Analyze and examine trends and projections. Gain market insights from subject matter experts. Biz Talk every Friday only on BNC. Gain insights from the people with the capacity to translate vision into reality. Interviews with corporate leaders. Monday, only on BNC. Hello Malaysia and welcome back to the final segment of Medical Today. And in the studio with me is Dr. Prabjot Singh Sidhu, a consultant gastroenterologist from Ramsay Sime Darby Healthcare. He is not only a gastroenterologist, he's also a hepatologist, yeah?
Yep.
So let's just get past this jargon first or this terminology, gastroenterologist and hepatologist.
Well, basically I deal with everything from your mouth all the way to the bottom.
Right.
Everything in here and your liver, basically anything in this section, all the stuff that is not dinner conversation.
Right.
That's what I deal with, yeah.
Okay, but the problem is, for the longest time, people only specialized in gastroenterology. Now it's a larger area that, yeah.
It is, because it's...
So if I have a problem with the liver,
Yes.
I see you because you're a hepatologist.
Exactly. Everything in this area here, it's all the pancreas, the liver, the gallbladder, all that is in the same section, the same area that's covered by a gastroenterologist and a hepatologist. It is slightly different, the areas we do, but it is all interlinked.
Right. One conversation that one would want to have with you is fatty liver. Everyone talks about it now.
Yes.
People are not fat, but they have a fatty liver.
Yes.
So the instant someone finds out that you have a fatty liver, they ask you if you drink.
Yes.
Now, not many of us drink these days,
No.
but we still do have a fatty liver. Why is that?
Exactly, because we are the fattest nation in the whole of Asia. That's the first thing.
Malaysia boleh.
Malaysia boleh, boleh gemuk.
Yeah,
That's
boleh
the first thing.
gemuk,
That's the
yeah.
thing, and you've done it. But the
Yeah.
thing is that fatty liver is associated with 5 times increased risk of diabetes, 3 times increased risk of colorectal cancer, and then odds ratio of heart disease by 10. Though it may seem asymptomatic, it is problematic. And it's a big problem there. 7% of thin people have fatty liver.
Right.
It's much more in Asia.
Right. So, okay, now that we're talking about fatty liver, and this is not in the script,
No.
I need to get this out in the
Sure,
open.
sure, of course.
It's like an elephant in the room and no one's talking about it.
Yeah.
Over the radio, you hear all the time, take this and your liver gets better.
There is no evidence that any of that is effective enough.
You heard it here on Medical Today, okay? No evidence.
Now, there are tons of supplements out there. The reason they're still called supplements is because there's not enough evidence.
Right.
And some may work, but did it work because they were going to get better? Or it did actually do something, not enough evidence. The current evidence that is there to fix a fatty liver is first addressing the cause. If you're an alcoholic, address that. Hepatitis B or C, address that. Or if you're overweight, or have high cholesterol, high blood pressure, address those things and everything will
It's interesting that I have friends, on the weekend, they like going for a drink or two and they tell me, they swear by it and say, bro, every weekend now I can drink a lot more because of this.
What, because of having that thing?
By taking liver supplements.
I think they're mistaken. They are probably doing something that, for example, there is evidence to say that people who drink beer is worse than drinking wine. But actually, they've done studies where you compare what shopping they did in Tesco, and you look at the wine drinkers, olives and all, cheeses, beer drinkers, burgers, chips. It may not just be the alcohol,
great things,
it's just the other things with it. So people also shifting from beer to wine. They're getting a bit posh.
Now, coming back to gastroenterology, there's a lot of misconception with regards to, let's just say, gastritis.
Yes.
To begin with, some people believe that it's the times you eat. Some people believe that it's stress. Some people believe that it's gas in your stomach. There's a lot of theories out there. So what's the 101 on this?
I think if you do have pain or any complaints, describe your symptoms. Don't just call it gastritis, because it may be something different to you, maybe something to me. As to causes, multifactorial. You can have H. pylori, which is a bacteria associated with gastric cancer. It leads more of these problems. Stress does play a part, wrong kind of food. Timing, unfortunately, does play a part in all of this. Now, when we're young, we think we're indestructible. We do anything we want. As we get older, we forget that we're not as strong as we used to be. It's a multifactorial thing, but it's not a matter of just gastric. It's the symptoms that you need to put together. You may or may not have that.
See, here's the interesting thing about gastroenterology. If you look at the medication being given out, I mean, a lot of different doctors, like physicians or internal specialists, have an arsenal and a range of medication. But you guys have your PPIs, you have your antacids, you have your histamine 2 blockers, and also your promotility agents. That's all you have to play with. And we've been using the same drugs for the last 25 years. Is there something wrong or is there something right here?
It's right, but it's not a full picture. You see, it's not a matter, you got a pain here, take these drugs, off you go, you'll be fine. It never works that way. It's all individualized. Now, you may be one that's stressed. You may be one that skips meals. Addressing those factors are as important as having the drugs. The drugs help you get better. But without addressing that your lifestyle changes, you're going to be on these drugs forever. And that's not the right way to go. Now, I spent the last 20 years in the UK. Majority of people there, you need to put them on medicines for whatever reason. They have to stay in a long time. 90% of my patients here get off medicines after 2 months, and they're fine. It's taking the time to delve into why this is happening. Is it really a problem? Is it actually medicines that you need, or is it just a subtle change in your lifestyle or how you approach things? And that does the job 90% of the time.
So what do you think is the problem? Because it really irks me when I walk into a pharmacy these days and you ask for a box of PPIs and they're telling you, no, take aloe vera juice, it helps. Like, come on, man.
I'm scientifically trained, so until I see the evidence, the hard evidence, I would not say have that. Okay, I mean, there is evidence saying the alkaline water and the Mediterranean diet is best for you if you had gastritis kind of thing. But that's about the only evidence there is, unless something new has just come up. But otherwise, it's your general lifestyle changes. The medicines get you from point A to B, but from B all the way to Z, it's your lifestyle. It's going to you're going to spend your time with your friends or spend your time seeing me on the weekend because of your gastric pain. So it's actually a very individualized thing, and taking control of your own health, that is as important as seeing the doctor.
Right. Now, what we want to delve into right now is, for a while in the 90s till about, say, 7 years ago, you get a lot of doctors having their own practice. Okay, gastroenterologists, you go to the clinic, they give you a shot, you go to sleep, they put the scope down your throat, they do a scope, then they wake up, they give you a DVD. You've got your well-produced DVD given to you. You can go home and check it out. But these things are fast changing, and now apparently transnasal endoscopy is the new sliced bread.
Well, it's not a new slice of bread. It's just not used as much here as it should be done. I mean, firstly, that CD you talk about. Do you know anyone's ever looked at the CD? Exactly.
I've tried.
Yeah, no, even if you look at it, you don't know what you're looking at. It's just, a bit of here, a bit of there kind of thing. Now, I'll put it this way. When you have a scope, you're going to have it down your mouth. Now, I dare you try this now. Open your mouth and try and swallow. You can't. The minute the scope goes down, you think, I need to swallow. And then when I tell you don't swallow, you're going to try and swallow. With the mouse guy in there, you can't swallow, you're going to panic. And then there, the first thing starts. And then it hits the back of your mouth, you start a gag reflex, which is, by the way, a very protective mechanism we all humans have. It's good. But everybody thinks something is wrong. And the endoscopists will start panicking, oh my God, the patient's being uncomfortable. They may rush, they may give sedation, which is not necessarily needed. If you explain the procedure properly, and then if you rush, you miss things, and so on and so forth. These are problems with your conventional endoscopy. Now, transnasal endoscopy is slightly different. How we do it is, you be sat opposite me, just like this. We spray and numb the nose, and the scope goes in the nose. Now, you probably think, oh my God, this is a big one. I'll give you an example. Now, I got these two little props. This battery, a AA battery, is the size of your standard scope that's going down your mouth. Now, it's pretty big. This little pen was the size of a transnasal scope. Now, it's a small pen. You can see the difference. I don't know if you want to zoom in, but that's it. Now, this goes to the back of the nose. It is not painful if you prepare it properly. And because it goes to the back and down the back here, a couple things happen. One, you don't need a mouth guard. You can swallow, you can talk. One patient decided to sing to prove a point. And she did. Not very good, but she did, okay? And then because it doesn't hit the gag reflex there, there's no gagging. And you have the whole test wide awake, set up, you can lie down if you like, and you look in the same screen as me. Now, when you look in the same screen, you not only have to listen to what we tell you about, oh, this is what you've got, and here's the DVD that you will never look at, but you actually see what's happening. You understand, and this is taking control of your own condition yourself. This is education. You see the redness, you see the ulcer, and you know, right, this is my problem. This is why I'm having the pain there. You understand it. Now you'll take more active measures to...
So if this is a great way with technology, moving forward with technology, now why aren't we using it? Why isn't it widely used in Malaysia?
Okay, well, in Japan is widely. I think the main thing is this, is the preparation that it takes for the nose. Some people they think nose, oh my God, something's wrong with the nose. But it's actually spraying the nose and numbing it and giving it a few moments to work. Now, there are studies to say which would patient tolerate better. Spray in the mouth, spray the nose. Spray the mouth, they'll happily taste it because they know it needs to go down. Anything goes in your nose, you firstly think, no, it must come out, not in. But it's just a spray. The way to look at it is the sensation is when you were a kid, you jumped into the swimming pool, a little bit of water went in your nose, that's what it feels like on the first spray. The more we spray, the less you feel, and it's comfortable for the patient. It's not picked up because the time and effort it takes for it. But if it's more comfortable for the patient, surely it's worth the time and effort.
So once you do a scope, what can you ascertain? So and how deep does a scope go?
A scope with regards to the conventional transnasal? Or
transnasal.
Exactly the same as the other scope. It goes to your esophagus all the way down, to your stomach, and then into your small bowel, D1, D2 in your duodenum. Exactly the same as a conventional gastroscope. The only difference is that this scope is primarily used for diagnostic. Because the channels are very small, if you have a big bleeding ulcer, it's not the right thing to do, then you need the conventional ones. But otherwise, it is the same. It is exactly the same. In fact, because your esophagus is always closed and something has to move it apart as it goes down, something smaller, size of this, instead of this, is surely more comfortable as it is. And otherwise, it's exactly the same.
Right. Now, for those of us with GERD problems, and those of us who've been suffering from GERD problems all our lives, they say there's surgery to help with GERD and all that. Some doctors say surgery doesn't work. What are your thoughts on this?
I think for this GERD business, it's a four-step thing. One is always lifestyle. It always, especially in Malaysia. Definitely.
I hate that. I'm looking for the magic pill all the time.
Do you know what? You know, lifestyle is not a matter of here, go fix it yourself. You got to see a gastroenterologist. We'll tell you how to do it. It's not figure out yourself. Then there's medicines. And the fourth one, I missed the third one on purpose. The fourth one is this reflux surgery kind of thing. But there are new things out in the market, things Stretta, for example, where it delivers therapy to the lower part of your esophagus that thickens the muscle. And that is done via endoscopy.
Stretta, no cuts, so it's like the new gym for the esophagus.
Kind of, pretty much. Yeah, you're right. And within 2 months, you're off your medicines. The thing's nice and tight, and you get no more reflux. You didn't need a cut. And if people worried about the cost, it's about half the cost, as far as I've been told. But it's not even something new. It's just people are not aware of the existence of these things.
Right.
So yeah.
So before we get a couple of more facts on transnasal endoscopy, let's talk about probiotics and kefir. There's so many things out there in the market. It's good for gut health, so on and so forth.
Yeah.
Do you give these things out?
No. I don't. You see, the problem is that you got one bottle that's got one strain, and then you got one that's got 16 to 18 strains. Right. Now, your small bowel is where you target these things. You got billions, trillions of bacteria, over 500 different species and whatnot. Now, you're giving one strain. If you give the strain that is missing, lucky you, then you might get a better result. But you give things that you already have, it doesn't do anything.
Right.
So it's very hit and miss with some work. But the problem
there's
is...
this strain LP299V or something that's meant to cure IBS.
No. You see, IBS also is a whole thing.
Don't believe what you hear out there.
No, you need to go and get the facts right. Now, probiotics is still an ever-changing thing, and recent studies, meta-analysis of old work and new ones really add very little. Now, what it really says is that it works better for some people, it doesn't. Now, I always tell people, why buy something from a jar when you can take it yourself? Kefir, yogurt, kimchi, all stuff full of probiotics. Try those things. But more than often, it comes back to the pure basics. Sitting down with a patient, going through what they have throughout the day, how they have it, altering those things. These probiotic things can help. There's nothing wrong with taking it. But don't put your bets purely on probiotics. You may have something else that's going on that needs to be addressed first, and then go from there. Now, probiotics has its role in very specific situations. For example, Crohn's disease, for example, antibiotic-induced diarrhea.
Jeez, we need to extend this to another hour, mate.
You can talk about 2 hours for probiotics.
Right. So,
here we go.
Before we go, we've got about half a minute left.
Yes, sure.
Transnasal endoscopy.
Yeah.
What is your final message with regards to?
I think when you need to have endoscope, know there's a much more comfortable way, a shorter way. You don't need to be sedated and have your whole day ruined. It's a much comfortable way to have your endoscopy that you probably need.
Right. On that note, we'd like to thank Dr. Prabjot Singh Sidhu, a consultant gastroenterologist. He's also a hepatologist from Ramsay, Sime, Darby Healthcare, joining us right here on Medical Today. If you have any inquiries with regards to medical conditions, if you have a question for our doctors, send it to medicaltoday.my. That's ask@medicaltoday.my, and we'll furnish you with your answer and also with a nice set of vitamins courtesy of one of our sponsors. Thank you very much for joining us on this week's Medical Today. I'm Gerard Ratnam signing off. You have a great weekend and a fantastic week ahead.
Brings you the latest in current affairs, lifestyle and entertainment, as well as one-on-one discussions with fascinating personalities. Only on Bernama News Channel.
Mengupas isu semasa, merangkumi politik, ekonomi, sukan serta hiburan, membawakan anda agenda pentas dunia. Saksikan Ruang Bicara setiap Isnin hingga Jumaat di BNC.
Laporan pelbagai dimensi memaparkan isu semasa, pelancongan, warisan dan budaya dari dalam dan luar negara. Saksikan jurnal bernama setiap Isnin di Bernama News Channel. Semuanya tentang anda.
Ini Lokman, trendy orangnya. Setahun 5-6 kali